київський вечір. Дуже радий вас всіх бачити. Ця подія викликана нашою ініціативою, яка виникла в Національній психологічній асоціації щодо покращення стану діагностики і інструментів, якими можуть користуватися українські психологи. Саме тому ми колись зв'язалися із Девідом, і Девід побажав, скажімо, надати нам свій власний інструмент. Він є автором цього інструменту, і цей інструмент ми сьогодні будемо уважно розглядати. Він дуже, це інструмент MHBS-2 в нашому перекладі. Цей інструмент дозволяє нам оцінити різні перші, те, що можна оцінити скринінгом, різні перші патологічні, психологічні нахили, але перш за все цей інструмент цікавий тим, що він досить цікавий, досить добре оцінює ризики суїциду. І саме цьому питанню ми хочемо присвятити в більшості цю лекцію сьогодні. Вона займе десь приблизно 1,5 години. Я зараз ще в процесі підготовки для вас файлів, які вам знадобляться під час цієї лекції. Посилання буде в чаті та в коментарях на каналі НПА на YouTube. Це буде посилання на Google Диск, де ви знайдете деякі переклади. На жаль, ми дещо не встигли і щось мені довелося перекладати автоматично, тому прошу на це не зважати на окремі помилки. Дещо і більшість було перекладено заздалегідь, і тому ця більшість документів вже підготовлена якісно. Я не буду представляти Девіда, якщо можна, він сам досить чітко і явно представиться зараз. Я лише прошу привітати його і дякую йому за ту можливість, яку він надає українським психологам, саме цей інструмент і саме цю лекцію в допомогу для подолання наслідків нашої війни і нашої гуманітарної катастрофи, яку зазнає вся держава. Дякую. Девід, прошу.
Oleg, Katerina, should I share my screen?
Yeah, welcome, please.
Okay, okay, I got it now. Hello, I am excited to be with you today. I'm honored to be here. Appreciate this opportunity. Our topic today is suicide risk, focused on screening and assessment. And you see my plan here. I want to spend about 10 to 15 minutes on underlying theory of suicide. We could go into depth with that. I don't really want to do this as a research or a scholarly presentation in that regard. This is more practical, but it will be very helpful to have some picture of the overall theory of suicide that we're working from. It makes the screening more understandable. It makes the assessment make perfect sense. And that leads to interventions that then all fit this theoretical framework. So we'll spend the first few minutes, 10 to 15 minutes, on the theoretical model that underlies our work. Most of the time, as you see, will be on screening and assessment. We will focus on 3 steps. Step 1 is what I view as broad surveillance population monitoring. We should be doing suicide risk screening with everybody that we can at every opportunity we can. It should be brief, self-administered, and not require professional intervention. It's just monitoring the population. The next step is to identify that subgroup who needs more individual follow-up potentially, where the risk may be higher. And so we have this step 1.5 is an intermediate step. And then what we'll spend most of our time on is this full suicide assessment interview, a clinical interview that thoroughly evaluates the risk of the person attempting a potentially lethal suicide effort. And then I'll close with a few minutes on intervention. This is not really for the focus of today, but when you do this full assessment, you find yourself automatically transitioning to some at least initial intervention plans. If the person is at higher levels of risk, you don't want them leaving your interview without some steps in place that protect their safety. And if we get through all of this in a timely way, it should leave 20 to 25 minutes, maybe 30 minutes for questions and answers. I'll try to respond to questions as we go. And I think our procedure is that you would enter them into the chat. And then one of the interpreters would interrupt me with that question, and I'll try to answer in real time. Otherwise, things that can wait to the end, there should be plenty of time there. So let's move to the theory, and just for the sake of giving credit where it's due, I want to recognize that much of our work is based on the 30-year research program of Dr. Thomas Joyner. He's a psychologist at Florida State University. This has been his area of focus for decades. And he is arguably, many people would say he's the world's leading suicidologist. I would agree with that. There are other people, obviously, in this area of research and other people that do really good work. Certainly, though, Dr. Joyner is near the top of anyone's list with 500 plus peer-reviewed publications in scientific journals, 56,000 citations, which is far more than most of us have. His most cited work with more than 3,000 peer-reviewed citations is his book, Why People Die by Suicide. I see it underlined here, published by Harvard University Press. And this is older books, 2005, highly cited. And one reason is this is when our language started to change. In English, we've had this unfortunate phrase of we talk about someone who committed suicide, or the act is to commit suicide. And that verb is used in other contexts, like to commit murder, or to commit a crime, or to commit adultery. It's used in these other contexts where it has a connotation of moral responsibility for this act. So in a way, it's like assigning some blame to the individual who dies by suicide. And Dr. Joyner has championed this change in our language to move away from that stigmatizing accusation to see this individual is really more a victim than a perpetrator of this act. So instead of saying the person committed suicide, we say that they died by suicide, or they killed themselves. That's a second language change that I would emphasize here, is that we tend to be nervous about this dark topic, even as healthcare providers. It's a difficult and scary issue for us. And we sometimes, our voice gets softer, or we ask indirect questions. We say, well, have you ever maybe considered harming yourself in some way? When what we're concerned about, have you thought about killing yourself? Have you thought about suicide? So the encouragement here is to just be direct in our language, to talk about someone killing themselves, to talk about dying by suicide, thoughts of suicide, suicidal ideation and desire, and to do it in a matter-of-fact and comfortable way, which then helps the client to feel more comfortable in talking about this issue with you, to destigmatize it to an extent. So Dr. Joyner gets credit for just an human amount of scientific research, but also for these cultural changes in how we think about and talk about suicide. Why do people die by suicide? Well, in the simplest framework, it's two reasons. Because they want to die by suicide, they want to kill themselves, and because they can, they're capable of doing it. Those are two very different things. Both must be present. So the quick answer to why do people kill themselves is because those are the people who want to do it and who also can do it. This is the same point, but made visually instead of verbally. And what we see on the left here is a set of people who want to die, who think about suicide, who have suicidal ideation and desire is the term we use. And there are a lot of those people. There are a lot of sad people in the world. If I were to ask everybody on this Zoom screen to raise their hand if you have thought about killing yourself, I'm not going to do that, don't worry. But if I were to, there would be many hands that would go up because this is not an unusual thing. Is having thoughts about suicide is not rare. It's not an unusual experience. And so that's really important to think about because we'll often encounter clients or encounter people in our lives who have thoughts of suicide. That in and of itself does not mean that they are at significant risk. And so when we talk about allocating resources or where do we spend our time, this alone doesn't do it. And it's very common. This other smaller group are people who have the capability for killing themselves. We also know people in our lives who have this capability. They tend to have traits like being bold and fearless and risk-taking and adventure-seeking. They jump off high places into water. They don't know what's at the bottom. They jump out of airplanes with parachutes, parasails. They become policemen. They join the army. So there are people who have this boldness and fearless approach to life. They are not afraid of death. But most of those people don't want to die. They're not afraid of death. They're fearless, but they don't have a desire to kill themselves. So it's just this overlap. Right here is who we're trying to identify with our screening and assessment techniques, is the people who want to die and who have the capability for dying. And I'll speak more about capability. That's a really important area for us to assess. It's easy to assess the ideation and desire, and we're used to doing that. Because a lot of these are depressive symptoms that we're used to dealing with all the time as healthcare providers. But capability is this other necessary piece of this puzzle that we'll spend some focus on. This is the same basic idea elaborated one more step. And this has to do with Dr. Joyner's model itself, the interpersonal psychological theory of suicide. And in his early research, really going back to the 90s, but it's maintained through the years, is when you are examining suicidal ideation and desire, he has identified two themes that are prevalent in the thinking of people who end up making a lethal suicide attempt. And one of those is he labels this perceived burdensomeness. And that is feeling like you are a burden to your family, or I'm a burden to my friends, that my people would be better off without me. I cost too much. I take too much of their time and energy. There's no payback for that. I'm a burden. I'm a burden to my people. And he would hear that thought over and over. And that's become verified by research as one of the types of ideation, suicidal ideation, that's more associated with actual risk. The second major concept here is thwarted belongingness. And that's a feeling of, I don't belong anymore. I have no people. I have no friends. And we'll talk a little more about both of these, but that connectedness to other people, when that bond is broken, when the person feels alone in the world, that they may express it as loneliness. But when you interview and inquire, what they're struggling with is feeling of not belonging to any group. And those two things together become more important types of suicidal ideation. They're part of this suicidal ideation and desire. But when you hear those and you're listening for those, they raise your concern level because they are elevating risk level. And then we see here on the right that at this time of this particular stage, the capability for suicide was called acquired capacity. We were focused on the ability for suicide that you acquire over time through experience. This concept is changed to is now just called capability for suicide. But again, we're trying in our screening and assessment, we're trying to identify the people in this overlap area that have both a sense of burdensomeness, a lack of belongingness, enhanced suicidal ideation and desire, and this capability for doing it. So this is the most elaborate I'm going to get theoretically. It doesn't get worse than this. What we see on the left here, I'm drawing a circle around this upper left part of this flow chart, of this block and arrow diagram. These are the elements of ideation and desire. And you can see they lead, this is pathway that leads to desire for suicide. We see thwarted belongingness, and it's associated with loneliness, with reciprocal care, people that I take care of and they take care of me. These are people that I belong with. It's a reciprocity or a mutualness in caring for each other. Perceived burdensomeness, I feel like a liability rather than an asset, and it can involve feelings of self-hate. And both of these things lead to passive suicidal ideation. Here we have the important construct of hopelessness that enters into the diagram. And is hopelessness primarily about thwarted belongingness and perceived burdensomeness? Is that I'm hopeless that these things will ever change. I'll always be alone. I will always be a burden to my family.
Зараз одночасно. Зараз були два одночасно перекладачі, якщо можна. Так, дякую.
Should I continue? Okay. So the desire for suicide we see reflected here in this ideation and desire. This bottom right has to do with the capability for suicide. And we see some biological and genetic factors that enter in, and that would be like this boldness and fearlessness and risk-taking. People are born like that. Painful events, including things like non-suicidal self-injury, cutting yourself or burning yourself, can increase your capability. And the mechanisms that have been identified in research as capability include lowering your fear of death. Humans, all animals, have a natural fear of death. We're biologically programmed to survive and reproduce. And so threats to that, we're naturally afraid of. We don't get too near the edge of a cliff. We avoid dark, dangerous situations. But if you are repeatedly exposed to death-related stimuli, you can habituate psychologically. And that fear of death gets lowered. Fear of death is really a good thing. It protects us from suicidal urges. But we can lower that fear through daily exposure or constant exposure or repeated exposure. Increasing pain tolerance is another issue that would raise risk. Pain keeps us from doing dangerous things. But if we are in situations where we are increasing our pain tolerance through, for instance, non-suicidal self-injury or military deployment is a famous, involves ongoing pain and exposure to death that raises these thresholds and raises risk. And so we get suicidal intent here at this level, and then when we add capability to it, these are the things that then lead to a potentially lethal suicide attempt. So one last update on the capability factor is we have got empirically, research has shown a family history of suicide raises risk. Serotonin-based issues, depression raises risk. Impulsivity is a personality trait. Exposure to other suicidal activities. So we see this in our teenagers who watch those shows on Netflix and social media where it shows other teenagers killing themselves. And there is a contagion effect. And so when you've been around suicide, then it can raise risk. Combat exposure has long been shown as a risk factor that increases capability and thereby increases suicide risk. Previous attempts is the single biggest predictor of risk. And we'll talk more about that, but previous suicide attempts should send off alarm bells in your brain when you're doing a suicide risk assessment. More recently, research has shown clearly through meta-analyses that childhood maltreatment is a risk factor for suicide in later life and suicide in adolescence or young adulthood specifically. So sex abuse, child sexual abuse, child physical abuse, and childhood emotional abuse are risk factors. So when we're doing our interview, we are listening for these things, and the way we understand them is that they contribute to this acquired capability, this capability factor, not necessarily the ideation factor, but they add element of risk. So last slide, when I want to break down the capability factor into three components that help you to think about it, that helped me sort out this this issue of capability, is there are three factors or three components, three different components of capability. One is dispositional. And so that would be like the things you're born with, like boldness and fearlessness and risk-taking and adventure seeking. Those people have this dispositional fearlessness that makes them more capable of killing themselves if that's what they feel, if that's what they want to do. They have higher capability. Acquired components we've talked about is increasing your pain tolerance through repeated painful experiences, and habituation to death stimuli that normally we avoid. We have negative reactions to open wounds, to death. We don't like to touch dead people. These are all natural reactions. But if you're constantly exposed to those stimuli, you become inured to them. They don't bother you. They don't set off those disgust reactions or avoidance reactions. So these things can increase over time. You can defeat your protective mechanisms by exposure. And then the practical components that become very important in our assessment are plans and preparation. So we're in the framework we're using, it's called resolved plans and preparation. Do they have a plan? Have they taken concrete steps to prepare for that plan? And we look at how are they going to do it? The means of suicide, the means of killing themselves. Is it with a gun? Is it with pills? Is it jumping off some high place? So we look at that, at the means, and say, how lethal is this? Some pills are far more lethal than other pills. Guns are always lethal. So the lethality is a key issue. Their ability to use those means. They may have a plan to use a gun, but do they have a gun? Do they know how to use it? Do they know how to load it? Did they clean it themselves? Did they disassemble and clean the gun? Where is it? Their ability to use the means is important. And then their exact plan is critical in every detail. How specific is it? What are the details? How imminent, how soon is it in time? And how specific is that time frame? So when we look, we all, I think, easily understand suicidal ideation and desire. But here on the capabilities side, thinking of dispositions, of these acquired components and then of the practical components helps us think through these. Let's look at the screening and assessment plan here. And really, what we've discovered, as have others, is that you really need to think of screening and assessment as a tiered process or as a graduated process. And I am a strong advocate of widespread brief screening. Now I like to think of it in the U.S. healthcare system, then it may be similar or different in Ukraine, is everything centers around the primary care outpatient medical clinic. Every town has a small bill medical center with maybe 10 doctors in it. And so people go there for their annual physicals. They go when they have a sprained ankle. They go when they have a bad upper respiratory infection. So much of about 87% of our population will see a primary care provider at least once a year. And so that's a primary place. I'd say we include suicide risk screening. It can involve a mental health professional. They're just not enough. It can't take any time. There's no time to spare. So this needs to be done automatically and in a very brief format and self-report by the patient. And so this, I'll talk some about this screening tool that we have, the MBHS, the Multidimensional Behavioral Health Screen. It's now translated into Ukrainian and it's available to you right now to use. It's all done over the web. You send your client a link and they click on it and take it on their phone and you get the report back. So it's a very, very quick, takes virtually no professional time. So that's a good way to do universal screening. We also, though, we're tuned into these spontaneous screenings, like did a family member express some concern? Did the individual themselves mention the term suicide or thoughts about killing themselves in an interview? It could be that their medical doctor or medical professional had some concerns and makes a referral. If we just look at this first screening, though, because of how common suicidal ideation is, there would be far too many people that would come to our attention than we can actually have time to do a full assessment of. So we need to funnel this down into a smaller number. And so this step 1.5 is a very brief interaction with a healthcare provider, behavioral healthcare provider, but at 2 or 3 minutes, 4 minutes in that time frame to say, there are some concerns here. Let me see if they're serious enough to move ahead with a full assessment. A full assessment is going to take 20 to 30 minutes of professional time. So that's a valuable resource, and you're unlikely to have the ability to do a full 30-minute assessment on everybody that has some concerns, everybody that's flagged with the step 1. So you need this step 1.5 to determine who's at higher risk and who is not. So we have a couple of different versions of this. In America, in our healthcare system, it's very high volume and very fast paced, and there's not much time. So we have a 2-question format that the medical provider can use in step 1, and then they decide, is this person at higher risk or lower risk? In a mental health setting where you have more time, we have a 9-question, takes about 5 minutes, and then you decide, is this at higher risk or lower risk? If they're at higher risk, then we do this, what we call a full Joiner interview, because of Thomas Joiner, we name it that. He doesn't call it that. It's just a full assessment of suicide risk. So I know it seems a little backwards, but this will make more sense to you if I start off with this full 2.0 assessment, step 2.0. And we go through it. It's 18 questions. And then we can look back then at the screenings that lead up to that, and they'll be quick and easy to understand. So let's go through this first one. And you've got this handout. Katerina, where is that? Is that on the Google Drive? Is that, how will they be able to find this? It would be good if they had this open as we talk through it.
Зараз у чаті є посилання від Олега Бурлачука про корисні матеріали для семінару. Це посилання на Google Drive, воно зараз є у чаті, ще раз окремо його продублюю.
Thank you. Okay, so there are 18 questions. I'm going to page through these and come back here. I've split that interview form that you have into 3 screens. And so we see the first 2 questions here, the next 6 questions here, and then on the second page, we have 9 more questions. But I'm going to go through these in sequence, so it'll make more sense. The first 2 questions here, you can see the label is suicidal desire and ideation. And so this is the way we're going to assess that left hand. Who has the desire? Who has elevated desire? So the first question is, have you been having thoughts of suicide or of killing yourself? Tell me more about that. And then you just listen to what they say. You be a therapist, you be a mental health provider, and a listener and a counselor. This is not a psychological test. This is not like you're giving a standardized instrument. This is what we would call this as a semi-structured clinical interview. And you don't have to do these questions in this order. If you already know the answer to the question because of your conversation with this client, you don't have to ask that question again. So don't treat it like a psychological standardized test. It's an interview guide or checklist. You won't end up knowing all the answers, but maybe not in this order. You're asking just directly, comfortably and directly, no beating around the bush. Have you been having thoughts of suicide or of killing yourself? Tell me about that. How often do you have these thoughts? How long do they last? How intense are they? And so that's this question here. I want to say a word about this informal scaling system. What we often use, you'll see 2 or 3 or 4 other places where we ask the person to give us a number. And so I'm saying, if you have told me that you have some thoughts about suicide, and I say, how often and how long do they last usually? Now I will ask you, okay, I want you to tell me when you have these thoughts about killing yourself, how intense are those thoughts? What's the level of intensity from 0 to 10? And that scale is not 1 to 10, it's 0 to 10. And the reason for that is we're not going to treat it mathematically. We're not going to use it in some formula. We're trying to understand how they feel. And 0 means there's no intensity. That's an absolute end of the scale. And 10 means they're at the maximum. And then we can judge in between because we know our client by that point. Are they someone who tends to maybe over dramatize or overstate their issues? Or do they have a stiff upper lip and understate things? So we know that about them. That's their response style. But whatever their style, a 0 means none and a 10 means maximum. So we use those 2 firm anchors at the end of the scale, and it helps us judge the level of severity here. Do you think about wanting to be dead? How often? How long does this last? So these are the questions. This is our assessment of the suicidal ideation and desire. And we give them all the time they need to answer those. There's space on this form for making notes to yourself by hand, or if you're using your laptop. Let me say a word about the scaling system over here on the right. Dr. Joyner does not use this. He rolls his eyes at this. I find it useful, certainly at the beginning, when you're unfamiliar with this kind of assessment, but it's informal. This is for as for recording your impressions. It's not numbers that we're going to add up to a scale. So basically, when you ask, how long do these last? And the person says, well, they just split through my mind. You might put a 1 for mild, but you're saying, is it not a problem at all? Or is it mild, moderate, severe? And you're just giving your impressions as you go. What does help down here at this very bottom line, suicidal desire and ideation overall, that number there, you really would just kind of look up above and see what numbers have you been giving. Now that you want to tell yourself, right as you finish up this part of the interview, what do I think about overall suicidal ideation and desire? Can I honestly give it a 0? If not, would it be a mild, moderate, or severe? And that will be useful to you later when you're putting all your information together to go ahead and if summarized this suicidal desire and ideation, this first part there for yourself. Just notes to yourself, not a score. This second area is, you see the label is resolved plans and preparation. So this is the longest part of your interview. It's the capability, you're getting at the capability here, at the practical aspects of capability. Have you attempted suicide in the past? Extremely important question. Make sure you know the answer to this and that you know it thoroughly. And you understand each of any previous attempts. Did you hurt yourself with the intent to die? Sometimes there's some confusion. It was self-injurious, but it may or may have been ambiguous in terms of, did they really want to end up dead? How many times? What methods did you use each time? What happened? What was the outcome of this? And that's really important to figure. What kind of consequences did they experience from that attempt? They may be helpful to you in your plan for intervention. If there was more than one attempt, when was the most recent attempt? And so here I'll say a couple of things that we know from research. There's a huge increase in the risk between one previous attempt and two. And this will make some sense when you think about it. First of all, let me say that any previous attempt is a warning, is a risk factor. Okay, one previous attempt should really get your attention. You want to explore it. But two previous attempts is the difference between 1 and 2 is bigger than the difference between 0 and 1 in terms of risk. Because a lot of people, they may get so desperate that they engage in an attempt to kill themselves, but it's not well thought out, or it may not be potentially lethal. It was painful though. They learned their lesson from it and they don't do it again. So we have, there's a population of people who've made one attempt and never make another. But once they've made the second attempt, they've overcome all those resistances and they've overcome the obstacles. And so now that is a very prominent risk factor in our framework. And so we separate between multiple attempters and non-multiple attempters. So multiples have 2 or more attempts. Non-multiples have 0 or 1. And the time factor is critically important. And this is an empirical finding, is that if that most recent attempt is more than 2 years ago, the risk level drops to as if there was no previous attempts. So there's a lifespan really of how these previous attempts figure in. Now, it could be 5 years ago. I would still note that it's a previous attempt because it does show as an indication of some capability, the fact that they even tried it once. And so there's some issues that don't go away after 2 years. But in terms of being this really alarm bell warning sign, if it's more than 2 years ago, it doesn't carry nearly the weight as if it was within the past 2 years. And just think, if the second attempt was last week, that's just almost in and of itself an indication of a severe risk. Okay, and you want to know those. You will regret later if you didn't know that third time, or that second time maybe. What did they use? What, if it was pills, what pills did they take? How many did they take? Where did they get them from? You want to know all of the details of each attempt. That will absolutely help you later. For how strong is your intent to kill yourself? This is a singularly powerful question. And when we get to the step 1.5, this is one of the two things. If we can only ask the person 2 questions, this is one of those 2. How strong is your intent to kill yourself? In 0 to 10 scale. 0 means you have absolutely no intent to kill yourself. 10 means you're determined. You're 100% committed, determined that you're going to. And so then in between that, you want to judge clinically the response style of your client. Did they exaggerate? Do they minimize? But the 0 and 10 are firm anchors to this. So it's a good scale to use. It's a really important question to ask seriously and make sure you are connecting with your client and you understand what they tell you. And then starting with 5, we get into the nuts and bolts of plans and preparation. Do you have any plans for how you would kill yourself? Tell me the details, the specifics. If you're going to jump off a bridge, which bridge is it? Where is it? How far is it from where you live? How would you get there? If they say, no, I don't have any plans to kill myself, ask them, have you ever had any plan? And sometimes that brings up a previous round of thinking about this that did go to the planning level, and that will help you assess risk better, help you intervene better. Do you know when you expect to use your plan? Timing, that's the time issue. Do you think you'll have the opportunity to kill yourself? Like it may need to be when nobody's home and so forth. Will that opportunity exist? Have you acquired the means for use in a suicide attempt? So if they say they would shoot themselves, that have you gotten a gun? Have you gotten a hold of a gun? What kind of gun is it? Do you have training in it? Do you have ammunition for it? Who taught you how to do it? Do you clean it yourself? Do you disassemble it and clean it? How did you know how to do that? Where is the gun? Where do you keep it? So have you made preparations for a suicide attempt? Is a little bit repetitive, but also really important. It involves acquiring the means. It involves storing them, practicing, or whatever. But things like, have you left a suicide note? Have you said goodbye to anybody? That's a really important warning sign. One thing that's been noted by researchers and by clinicians over time is when people start giving away personal possessions, that's preparation, that's resolve preparation. So you have these 6 questions will guide you through the plans and preparation part of this. And so again, at the bottom line here, we can use these numbers or you cannot. Again, many experienced clinicians don't bother with this. I would say when you start out, it's kind of helpful to put mild, moderate, severe as you go through these questions. It's going to be helpful, though, in any case, at the bottom line to say, where are they in terms of resolve plans and preparation, and to be able to indicate there in real time as mild, moderate, or severe from your own judgment. Finally, the last 10 questions are on the second page of this interview form. And really, you see the rubric is different here. You just say yes or no, present or absence. And what these are other risk factors. And these have been determined by research. You'll recognize some of them from the theory. Have you ever caused yourself physical harm by cutting, burning, or other means without the intent to die? So this is that non-suicidal self-injury category. And so that's considered to be an other risk factor for reasons that we can surmise. It's like practice, or it's elevating a pain threshold and so forth. So it's a risk factor. Any history of self-injury or suicide in your family is a risk factor. Do you feel confident you could attempt suicide? Do you feel afraid to die? So this question really is dealing with the fearlessness about death factor. And if they're fearless about death for whatever reason, even if it's a religious reason, then that lowers a barrier to suicide. So it becomes a risk factor. Do you feel connected to other people? Do you live alone? Do you have someone you can call when you're feeling badly? Who? That question is dealing with the concept of thwarted belongingness. Do they have any sense of belonging? Or are they without that? Are they severed from other people? That becomes a risk factor. Sometimes people think the people in my life would be better off if I were gone. Do you think like that? Do you ever think that? It's a way to get at that perceived burdensomeness. Do you feel hopeless? Tell me more about that. Has anything stressful happened to you recently? I don't know in Ukraine if you even need to bother with that question. Wouldn't you just circle yes? I would think without taking the time to ask. Number 16, when you're feeling badly, how do you cope? And then you prompt them. You give them some freedom to acknowledge some negative behaviors. Like sometimes when people feel really badly, they do impulsive things just to make themselves feel better temporarily. Has this ever happened to you? These are things like cutting your skin, getting drunk, running away, binge eating food that's not good for you, promiscuous sexual behavior, physical aggression, stealing or shoplifting. So you're making it okay to admit those things, saying that these are things that people do sometimes just for temporary relief when they feel badly. And that would be a risk factor. Maladaptive coping behaviors is what that would be. And you would circle yes, and that becomes an other risk factor. And then 17, warning signs. You see a list here of 7 things: agitation, social withdrawal, insomnia, nightmares, marked irritability, severe affective states, emotional extremes, significant weight loss. Those are warning signs that have been observed by clinicians in patients prior to a lethal attempt. So they're not, we see those in lots of other settings too, but I'm saying in the context of a suicide risk assessment, any of those that appear would have you circle yes on this, so that becomes an other risk factor. And then finally, 17 and 18 aren't questions you ask. 17 is an observation, okay? 18 is a history issue. You look in their chart. Is there any past diagnoses like major depressive disorder, bipolar disorder, borderline personality disorder, thought dysfunction, eating disorder, substance use? Any of those things you would circle yes, and then that becomes another risk factor. So these 10 questions really is just 10 kind of quick things. You may know already the answers to some of those, so you don't necessarily go through them one at a time. You go through them in your own mind as a checklist to make sure you do know the answer. If you don't, ask the question. And so and then at the end of this, you're going to have circled yes or no for each of these, and all the yeses then become that's how many other risk factors there are. I want to say one quick word here. I've already said this before. Don't take this interview as if it were a standardized psychological test. This is a clinical tool for you to help us make sure that you've gathered all the information you're going to need to make a risk determination. But you can do it in any order. You don't need to ask questions if you already know the answer to them. If a lot of times you'll ask one question and it opens a floodgate, and they go on for 5 minutes. And during that 5 minutes, they're telling you a lot of things that you need to know in this interview. So be flexible. It's really important that you see this as a clinical encounter, that you're being partly assessment psychologist, but partly a therapist in this context. And you get the most out of the individual that way. And you're just recording it here to help you make your risk determination. So the other handout that you've got here is the decision tree is the terminology that we use here. I'll put the Ukrainian translation of it up here. And so this path through here really just helps you separate low risk from at least moderate. And that's really important. That's a really important distinction. That's what we try to do with screening. You say, can we safely assume there's low risk so we don't need to do anything more with this person? Or do we have at least moderate risk, which means that we need to do some things? And so in particular, to be concrete about it, if a person is showing moderate risk or higher, at least moderate risk, then they need you need to do a safety plan with them before they leave. So that's actually an intervention. But when you get into full risk assessment, you may find yourselves you may very well find yourself in a situation where your client has elevated risk to at least a moderate level. And you need to then you finish your assessment, but then switch into the safety plan with them, which will take another 10 to 15 minutes, 20 minutes perhaps. But then that allows a plan to get underway. So anyway, to look at this, first thing you look at here on the left is, are they a multiple attempter or a non-multiple attempter? And if the answer is yes, that they are a multiple attempter, then you go all the way to here, and it's that if there's any other significant finding, any risk factor or any other significant finding like elevated desire ideation, then they are at least moderate risk. If they say no to that, they're not a multiple attempter, so they're 0 or 1. Then the question is, are they elevated on resolved plans and preparation? And that was the second part of your interview. And if they are elevated on that, then you come back to this box and say, if there's any other elevation, like on those other risk factors, then they are at least moderate risk. If they're no on that, you then ask, are they elevated on suicidal desire and ideation? If the answer is no on that, then they're at low risk. That's good news. Okay. If they are elevated on that, then they would need 2 or more other significant findings, 2 or more risk factors to reach moderate risk. If they have 0 or 1, they can be elevated on suicidal desire and ideation. But if there are no other risk factors or just one other risk factor, then they can still be low risk. But if they're 2 or more, then that elevates them to moderate. So then, as you're distinguishing between moderate, severe, and extreme, you just need to read these descriptors under those higher risk level categories. And they'll have to do with where you end up on this action plan here. And so you see number 4 is the point at which you do a safety plan. And I've got this. And so we'll get back to the safety plan. What I want to circle back here and talk about the screening, the 2 levels of screening. In step 1, the MBHS, this is the tool you have now. So you send a link to your client, they fill it out on their phone, and you get this report back. And the top part of the report is this graph. So it is screened 3-item scales all for 9 things. These first 2 are somatic and cognitive. The next 4 are internalizing, like depressive and anxiety related. The last 3 are externalizing, like aggression and conduct and substance use. So here, the one that's feeding our process directly here is this 4th one, the internalizing, is suicidal ideation and desire. The scaling here, this dashed line is the 50th percentile of the comparison group. The comparison group is a U.S. primary medical care outpatients. So that may or may not be a useful comparison point for your population, but it's what the instrument was developed on. This dark bold line is the level of clinical elevation. So anything up above this line is potentially something that needs treatment or intervention. So here we see the suicidal ideation scale is above. So that's measuring just ideation, not full risk. When you get just below this graph, what you'll see is this little breakdown. It's an algorithm which replicates that chart we just looked at, that decision tree of previous attempts, resolved plans of preparation, ideation and desire, how many other risk factors. And then it yields an outcome of risk being low risk, mild, or at least moderate. And this is done for you. I mean, you've not even seen the patient yet. This is automatic screening that they do through self-report. And to give you a kind of an accurate sense of what these ratings are, if it says low, it says that the risk is low. That should, in the population where it was developed in, is outpatient U.S. medical clinics, about 80% of the people fell within this low category. And that was accurate 99% of the time. They were actually low. So that's a very trustable rating. If it says low, it means low, and you don't have any risk that you need to worry about. About 15% of the people produced this mild level that's in between low and at least moderate. So it's a mild level of risk. So basically, I said we can't really say with confidence, is it low or is it moderate? There's a cost either way. If you could call everybody at least moderate, you're creating a lot of work for the healthcare professional who's now got to do additional interviewing. So mild, when we get to mild, about 15% of the population there, and about 20% of that group will actually be at least moderate risk. So you can't ignore those, but that's why we have a step 1.5. Is we have just a short interview, spent just a couple of minutes saying, is this person, do I elevate them to at least moderate, or do I lower them to low? And so you can say about 20% really will be moderate. So you want to pay attention to that. If the screener says that they are at least moderate, I would go ahead and do the full interview if at all possible. About 40% of that group will be elevated to at least moderate risk. So the screener, this screening output is really useful to you. It means you can trust the low. If it says mild, do a real quick step 1.5 screen. If it says at least moderate, then you go ahead and do the full 2.0 interview. This is the quick version of the mild step 1.5 are these two questions. And you've seen both of them really. This one, you have indicated some thoughts about suicide. On a 0 to 10 scale, how strong is your intent to kill yourself? Tell me, if you were going to kill yourself, how would you do it? And you listen for the means, the lethality, specificity, availability, and the time frame, specificity and imminence, how soon? And then you make a judgment. Do we need to go ahead and do a full assessment, or is there low risk here? If you have time and mental health settings and you get a mild indicator, which is a possible risk, these 9 questions here it's just a short form of that full 2.0. Are you currently experiencing ideation? Tell me more. Frequency, duration, intensity. How concerning is this to you? Do you feel you are a burden to others? Do you have a fear of death? Do you have a history of suicidal ideation or past attempts? What supports and resources do you currently have in place available to you? Are you engaged in therapy or counseling? So this is kind of a useful mini interview or a short interview. It takes about 5 minutes, maybe a little less if there's not much risk. It helps you decide, do I go to the full assessment or do I not need to do that? A lot of times this is used in a lower volume, like in mental health clinics, and you get some indication of maybe suicide risk. Then this is what the clinician would do before they make the decision to go ahead and do the full assessment. In medical settings, this one works because it's such a high volume, it's such a fast pace. So one or two of these may be relevant in your environment where you work, in that it's context dependent. So let me talk about a safety plan. And this, I think Oleg was going to have a translation done of this, but it may not be a good translation. He was going to have a robot do it or automatic translation. But this is what you may end up doing at the end of your assessment if you've determined that they are at least moderate risk. And so you can see from the safety plan, this is something you do interactively with your client. You pull it out either on paper and you do it with a pen, or you do it with your keyboard with a Word document on the screen, but your patient can see the screen. and you do this interactively. And the second page of this is what it gives you prompts. This is just for you, but it's addressing each of these areas. So for the warning signs, this first area, you'd say, how will you know when this safety plan should be used? What do you experience when you start to think about suicide or feel extremely depressed? And then you list the warning signs in the patient's own words. These are going to be unique to them. And what you're asking them is what goes on in your head when you feel like you're cycling into one of these suicidal crises, one of these suicidal episodes. What are some of the early indicators? And you put those down on the safety plan, but they're unique to that patient. Second, for internal coping, what can you do on your own without contacting anybody else? And this may be things like yoga or TV shows or going to the park or some physical activity, and that they can do in order to head off this suicidal episode or that's coming up. Third section is social contacts and places that provide distraction. And you're specific, you have names and phone numbers. Now, these are going to be friends or acquaintances that may not be aware of this suicidal ideation issue, but they are people that are fun to be with or that you do things with that are just social activity. Go to the coffee shop with, or take a walk with, get together with, but you're not planning really to talk about your suicidal ideation. Or places like a park that you go to, or to a museum that would distract you and normalize your thinking instead of cycling into a suicidal episode. Step 4 is escalating one more group, people whom I can ask for help. So these are people who know you struggle with suicide. And so what names and phone numbers, first person may not be there, or they may not be in a position to be able to talk with you. And so you have, 3 that you would take about you can be more open with. They are aware of your suicidal problems. And then professionals would come after that. Your therapist, your family doctor, the urgent care, emergency numbers. So these are in order, a graduated plan you would take when you're feeling suicidal. And then things that you can do to make the environment safe. And this is, you think incrementally here. I've learned a lot about things I would have never thought of. But you do anything that makes the environment incrementally safer. Like if a person has a gun is lethal. The gun is an extremely lethal suicidal means. So what you try to say, would you be willing to let your brother-in-law keep your guns for the next month until we have a better plan in place with regard to your suicidal urges? Can you put the gun somewhere else, somebody else's hand? A lot of people won't do that. They say, no, I have to have my gun there. So you can say, where do you keep it? And say, I keep it in the bedside table, so it's there to protect me. And also if I wanted to kill myself. And so where is it in the bedside table? Say, I keep it in the drawer up closest to me. And you may negotiate, could you move it to the far side of that drawer? So it's at least just a little further away. That's progress. That is lowering risk. Doesn't seem like much, but it takes risk down a notch if you can make the environment a bit safer. And then the last question is a good one. You have them tell you in their own words, and you put it on the safety plan. Tell me the one thing that is most important to me and is worth living for. So that's ending on a positive note, giving some. You're combating hopelessness is what you're doing with that. You're giving them some hope. Okay. So the summary here is you try to screen everybody often. The MBHS is made for that purpose. There may be other processes that you're aware of that are already incorporated into your work environment. That's fine too, but just getting it out in the open. Ask suicide questions is the name of one of the instruments that's become popular in pediatrics here in America. But this step 1, universal screening is what I advocate. Every patient, every visit, or every opportunity. Population surveillance. It's a public health effort. Second, follow-up is warranted with a brief interview, one that fits your work context. It could be that very limited 2-question one, which is pretty well thought out. It's a pretty, if all you got is a minute, that's a pretty good way to use the minute. A longer version is better. But what you're trying to decide is, do I need to go to that full interview that we went through, that full 18-item interview? And then have it ready and be comfortable with it. And when you start into that full 2.0 interview, you want to have your safety plan form ready to employ, because you may end up that interview kind of shifts from assessment of those risk factors into, let's make a safety plan and think of next week, and either you're going to come back and see me, or you're going to have an appointment with you for a therapist. But to get you from now till then, we need this safety plan. So that's why that intervention is there. All right, ran slightly over. Maybe I can blame Oleg for that, but we still have a little more than 20 minutes that we can answer any questions that you have. Come back to see me, or you're going to have an appointment with you for the therapist. To get you from now to then, we need this safety plan.
Дуже дякую. Я попрошу вимкнути мікрофони, щоб не дублювався звук. І ми маємо зараз, дуже дякую вам за вашу презентацію, професора Маккорд, і маємо зараз ми одне питання у чаті. Я його зачитаю і також озвучу учасникам, що ви маєте можливість задати питання також голосом. Для цього скористуйтеся опцією підняти руку і можете озвучити своє питання до професора Маккорда. Отже, питання від Маргарити Єгоренко. З якого віку ми можемо проводити цей скринінг? David, are you here on the English channel?
I'm here on the English channel. Yes, I didn't hear an English question though.
Okay.
Should I stop sharing my screen, do you think? Or it could be that people have questions where we need to go back to slides. What do you think, Katerina?
I think that for some reason you are not hearing the interpreter.
No.
Yeah, I figured that. So I will voice out the question is from what age can we conduct this screening? What is the age range for the screening?
That is a great question. The screening was developed on adults 18 and older, and that's where our strongest norms are. People are using it comfortably with adolescents down to about age 12. But below that, we have no experience and don't recommend it for pre-puberty individuals.
Дякую за вашу відповідь. Так, наступне питання. Коротка перевірка, чи маємо зараз переклад для Девіда? Did you hear the question, David? Did you hear the translation? No, okay.
I heard the Ukrainian, but not the English.
Okay, that's okay. Next question is from Ilona Shevchenko. How do we differentiate intentions to manipulate this screening from actual, not tendencies, but from actual desire to commit suicide?
That's a good question, and I've not thought much about that. And one reason is it's rare that this, with adults, in most mental health settings, it's rarely used in that way. Now, if you're dealing with teenagers, you know, it could be a manipulation, but we generally tend to take things, suicidal talk and threats at face value. And so we would do the full evaluation for sure and develop a safety plan for sure. Even if you suspected there was, it was not fully genuine, you'd have to weigh the cost of that. That becomes a therapeutic question pretty quickly. In terms of the suicide risk, we would take it at face value.
Thank you for your answers. I will switch to the Ukrainian channel and ask if there are any people wanting to ask the question by themselves. And we also need to check why the interpreters can't translate it in English. Колеги, чи маєте ви ще запитання? Да, пані Євгенія Василенко, дякую. Я вам зараз надам слово. Єдине, що маленька перевірочка з англійського перекладу. Пані Галина, пані Ірино, чи вас чує Девід на англійському каналі? Можете перевірити, будь ласка, і ну, я коли переходжу на англійський канал, він чує мене, того я не впевнена, чому щось тут, що відбувається. Я зараз з пані Галиною спілкуюсь, так? Да? Ага. Окей, клас. Добре, я тоді зараз переконаюся, чи включений. David, a quick question. If you are on the English channel yourself, can you please check it in the interpretation option?
Please stop this here. I don't even see that. Okay. Now I'm in English. I was not.
Right.
Yes.
Perfect. Thank you. Чудово. Так, то проблема вирішена. Пані Євгенія Василенко, будь ласка, задавайте ваше питання.
Доброго вечора. По-перше, хочу дуже подякувати за сьогоднішню зустріч, тому що це дуже на часі і дуже корисний матеріал. Так, і моє питання наступне. Як діяти, якщо клієнт недостатньо відверто відповідає на питання? Наприклад, людина може соромитись своїх думок про суїцид чи з якихось інших причин не хоче відповідати відверто, і тоді результати можуть бути, ну, якби хибними. От, що в такому разі ви порадите робити? Дякую.
I recognize the issue certainly, and one thing that I alluded to at the beginning is you want to be comfortable yourself with this topic, so that you're communicating being at ease, comfortable. It's normal to talk about suicide. Many people have thoughts about killing themselves. And it's something that we are comfortable talking about. It doesn't make me anxious as a therapist, or it doesn't make me uncomfortable. I'm here to talk through that with you. I do it all the time. Suicide is a tragedy for people and for families, and we're doing everything we can to lower the rates of it, but we have to talk about it. So in your interactions with your client, you want to make it a comfortable topic, and it needs to be comfortable for you. And so that's just a clinical interaction. In terms of their screening, you know, we're not really having any contact with them at their screening. And there is, we know this empirically. Some people will deny suicidal thinking on the screener. They don't want to tell the computer, or they don't want to just report this on a form. It's too personal and they're too uncomfortable with it. So they really may be struggling with suicidal thoughts internally, but they mark the questionnaire zeros. But then when you meet them and you're interviewing and you're talking and establishing a relationship, they will be more forthcoming. And you sometimes will find legitimate risk that just was not picked up by the self-report screener. It's a mode issue. It's not much we can do about it. It's a small problem. It's a small number, but not zero that will do that. And it's about the same number in reverse. Some people are comfortable answering the questionnaire honestly, but when they're sitting there with another human being in contact, looking at you face to face, they are embarrassed, as you said, and they're uncomfortable about acknowledging that. They'll downplay it. So those are response style issues that one way that we deal with it is we use both formats. You give people an opportunity to respond to these questionnaires in their own privacy on their own phone. And then you give them another opportunity where you're in human contact. And by combining both methods, you have a good chance of capturing a more accurate impression of most people. But if they're determined not to reveal those, there's nothing you can do about that.
Дякую. І невеличке продовження мого запитання. Я військова і працюю з військовими, і чи можна використовувати саме цей скринінг для військового середовища, тому що там є така ситуація, що трапляються не тільки заплановані суїциди, а й ситуативні. Тобто людина заздалегідь наче як не планує, не розробляє, але ситуативно може це скоїти, тому що у військових є доступ до зброї і доступ до певних ризиків в життю, і в певній ситуації людина може таке з собою зробити. От чи можна якось, користуючись саме цим скринінгом, якусь таку тенденцію до цього виявити? Дякую.
Yes, that's a really interesting question and a great one. The MVHS is used often in veterans hospitals. It's not used in active Department of Defense settings that I know. But Joyner's theory, the theory that we used here today, has been heavily adopted by the U.S. military. In fact, much of Dr. Joyner's grant funded the Department of Defense. So all of these issues are quite relevant, but there are going to be different values there. And you said it very well, is that you're dealing with a population that compared to the general population is going to be much higher in capability for suicide. Their choice of career, their daily exposure raises pain tolerance. It lowers fear of death because they're surrounded by it. They've got lethal means at hand everywhere they look. So you've got all of the risk factors associated with capability for suicide are really elevated significantly in that population. So it won't take as much suicidal ideation in order to reach that critical tipping point of making a lethal attempt. So they would, a lethal attempt could occur in situations with lower levels of ideation and desire, because you've got such higher levels of capability. And the instrumentation, the interview form itself, I know works perfectly fine in military populations. It is being used in military populations now to a wide degree. But your decision points, your cut points would shift because of that context. And I would be concerned I would raise the risk level at lower levels of suicidal ideation and desire in your population than I would in the general population.
Дякую дуже за ваші відповіді. Я бачу, що одне з питань у чаті вже людина отримала, пані Ганна Ланіна отримала відповідь на своє запитання з ваших відповідей. Ми маємо 2 людей у черзі і ще одне питання у чаті. І я думаю, що ми можемо тут підвести з огляду на час, щоб це останні 3 питання, щоб ми їх ще встигли розглянути. То я передаю слово пані Оксана Лисенко, будь ласка.
Дякую. Я писала там в чаті, але я можу озвучити це саме питання. Питання таке, чи правильно я розумію, що оцінку проводимо, якщо бачимо або підозрюємо на діагностиці депресію, тривожність, ПТСР, можливо, ПРЛ, тобто є якісь нав'язливі думки, паранояльного характеру, можливо, і ми їх відчуваємо, що вони там є, вони якось проскакують, то там перший, я так розумію, ми спочатку перший крок робимо, якщо там підтверджується, робимо і другий, якщо підтверджується другий, то робимо 3-й крок.
That's right. So the paranoid thinking, the PTSD, the depression, those would all fit into your interview form in that question 18 is clinical diagnoses that would count as other risk factors. And so that's how they would fit into the formula, is that they do ramp it up 1 level. And you'd follow the process and follow that decision tree, and each of those diagnoses counts as what is any one of them would mean that question 18 would be marked yes, and that counts as 1 other risk factor or 1 other significant finding is the terminology.
Дякую. І ще в мене одне коротке питання. Чи ми можемо задавати питання в якомусь довільному ритмі, чи в певній послідовності потрібно?
You should ask, I wouldn't say ask randomly, but you should change the order freely. And what you want is an interview that feels natural and therapeutic and comfortable for that client. So there's no set order to these. You can switch around and come back to another. If you get through the whole thing and you realize that there's 1 question you don't know the answer to, just go back to that question and say, I'm sorry, there's 1 more thing I want to ask. You can go back to an earlier question, but they do not have to be in any order.
Дякую дуже.
Дякую вам, Оксана, за запитання. І пані Наталя Липка, будь ласка, ваше запитання. Пані Наталю, чи маєте ви запитання, Наталія Липка, чи просто випадково піднята рука?
Ні, я маю запитання.
Будь ласка.
Даруйте, буду без відео, бо трошки зв'язок плаває.
Окей.
Що я хотіла зауважити, не завжди всі люди, які підпорядковуються ризику, хочуть проходити тестування. В мене син на нулі, і, власне, там в нього побратими до мене зверталися, і що казали, що їм просто погано. Я не давала їх, не ставила офіційно до відома, що я їм роблю тестування. У мене ті тести вже давно є, вже я ними рік користуюся, вони там поступово додаються. Спочатку їх було щось 4 чи 5, а тепер більше в тій програмці онлайн. Чудова програма. І ті тести, я просто питаюся по тестах. Я не кажу, що я проводжу тестування, я не доводжу до відома, тому що воїни на нулі, вони мають дуже чутливу нервову систему, а ті тести чудово дають тобі інструмент, чи він є в групі ризику, чи нема. І в мене є питання, чи доцільно так робити, коли людина в такому стрес-мажорному обставині, чи доцільно це робити так, як я робила. Тому що я не повідомляла воїна, а повідомляла відразу ротного.
Yeah, I'm not prepared to answer that question comfortably. It is a unique circumstance and an extreme one, and I am hesitant to endorse it as an ethical and moral practice, and I'm very hesitant to say that it's not. It's clearly well intended, and your effort is to help those individuals in less extreme circumstances. I could see that it's intruding on their rights to an extent, but is that a luxury that I can make from a country that's not at war? You know, I'm certainly not in any way judging your decision to do that, but I'm not sufficiently informed. I have not thought enough about these unique context that you're in to be able to give a meaningful answer. I'm sorry, my heart is with you. I wish I could be more helpful.
Дивіться, ну там результат позитивний. Ротний, ну, тобто старшина забрав зброю в того хлопця. І той хлопець тепер, ну, йому нічого не сказали. Він просто тепер допомагає більше там наряди по кухні, такі безпечні для, ну, він не знав, що в нього, ну, тобто він навіть нічого не знає, ротний забрав зброю, сказав, що тепер буде так, поки що. Ну, от, ну, добре розв'язалося.
Right, I hear that. It sounds again, my heart is with you. It sounds like the right thing was done. Sounds like good was served. It's just when you're asking me as a psychologist representing.
Я маю сумніви, чи це, розумієте, я маю сумніви, ну це як виняток, так? Це от стався виняток, бо людина плакала в ночах. Це був такий, ну, чи це дуже етично по відношенню до клієнта? От в чому моє питання. Я більше не планую так робити. Це не є етично, це був форс-мажор. От в чому питання не тільки для мене, а, мабуть, і для інших людей, наших колег.
It's the ethics of that are too complicated for me to sort through just spontaneously here. There's certainly a level of which I embrace what you did, and I'm glad that you did it. And the good was served by that. People were helped by that. But to now endorse that as a standard practice going forward is something I would just have to stop and think about more carefully.
Дуже дякую вам, Наталю, за ваше питання. Насправді, я думаю, що ми зараз ведемо розмови з лекторкою, яка може нам прочитати лекцію про етичні всякі стандарти у роботі з людьми і військовими у тому. І я думаю, що це дуже важлива тема, і вона потребує дійсно таки окремого обговорення. І дякую вам за те, що ви її підняли. Можливо, колеги впізнали свої кейси у цій вашій розповіді і винесуть їх далі на супервізії. Будемо намагатися висвітлювати і цю тему також, тому дуже вам вдячна за питання. Дякую вам, пане Девіде, за вашу відповідь і загалом за вашу лекцію сьогодні, за вашу допомогу і за вашу присутність з нами, за вашу підтримку. Дякую всім колегам, хто долучився до там останніх хвилин. Ми мали full booking, у нас повна загрузка була. Нагадую вам, що Цю лекцію ви також зможете переглянути на Ютубі, повторити якісь моменти. Правда, дуже корисний інструмент і на часі ця лекція. Окрема подяка сьогодні нашим перекладачкам, пані Галина, пані Ірина. Як завжди, чудова робота. І дякую вам за підтримку нашої асоціації. І ці події, вони були б зовсім іншими без вас. Тому, пане Девід, чи маєте місце для заключного коментаря, чи бажаєте щось додати, озвучити?
No, I appreciate the time today, and for everyone who signed up to participate. It's a great honor to be with you. And I have my lapel pin that, and I try to dress like President Zelensky when I can, and my thoughts are with you. And please keep my email address that you saw there at the end, and don't hesitate to email and follow-up questions, and I would be as helpful as I can, and I certainly enjoyed this experience today.